All right, we are up to lecture 9. We're just about through this stuff. Today we talk about atrial-septal defects, ventricular septal defects, and atrioventricular septal defects. So, starting with chapter 9, atrial-septal defects. Well, they are among the most common forms of congenital heart disease. Unfortunately, they are rarely diagnosed antenatally. The exception is a primum defect. Those do tend to get picked up antenatally. All right. So, of the atrial septal defects, a primum defect is the most commonly diagnosed one antenatally. But after birth, secundum defects are the most common. So, in a newborn or child or whatever, 80% of them are going to be secundum defects. And the other two types of atrial septal defects, which allow for an interatrial communication, are sinus venosus defect and coronary sinus defect. All right, let's pull a couple slides back from the early on lecture of embryology and talk about atrial septation. Just makes it easier to understand atrial septal defects. So early on, you start with a common atrium. Basically, there's a widening of the tube. And this common atrium starts to get separated into two distinct atria. The first septum that starts to form during fetal life is the septum primum, first septum. And if you look at the picture there, you can kind of see that it starts as a little outpouching from the top of the heart between the two atria, and it gets pulled down like a Venetian blind. So you're pulling down the blind from the top, and you're pulling it toward the crux of the heart. Now, as you pull it down like that, the remaining hole, meaning you haven't quite gotten there yet, that first hole there is the foramen primum. Now, eventually, the Venetian blind is going to hit this crux or endocardial cushion, and the foramen primum will have gone away. There is no foramen primum at the end. Now, before that happens, before that first hole closes, what happens is the upper part of the Venetian blind starts getting little holes in it. And these tiny little holes coalesce into a new hole. So remember, we call that a fenestration. Fenestration basically means the development of a window. So we've got these bunch of little holes that just start showing up on the top part of it. And eventually there's so many holes that they coalesce into a new hole. And this is the second hole called the foramen secundum. All right. So the next thing that happens in the lower picture there is in the right atrium, another Venetian blind starts getting pulled down. And it starts getting pulled down, and it almost gets there, but it stops. And it leaves a gap, basically. And that gap, or that hole, is called the foramen ovale. All right, so basically, now we have two separate septae between the two atrium. And the holes don't line up. You can see the green one is the septum primum, a bunch of little holes that coalesce together, and the septum secundum contains a hole, and that's called the foramen ovale. So what happens is these kind of move together, and this septum primum simply becomes the flap of the foramen ovale. So here it is, when the two are pushed together, you've got two holes that don't quite line up. So the blood goes from the foramen ovale in, up, and over the flap of the foramen ovale. So it's a partial fusion of the two. All right. Now, when it comes to the septum formation, it's kind of confusing. What is the top that we're talking about? Because typically we look at the heart, and in this view, this is an en face view, where we're kind of looking at the surface of the atrial wall, interatrial septum. The top of the atrium has been removed so that we can see inside, and what we're looking at is the interatrial septum. And when we're talking about pulling down from the top, like where is the top? And if you look over on the right, basically kind of tilt the heart so that the top, what we're talking about, is the part that's furthest away from the atrioventricular valve. So that's actually the top, and that's where the Venetian blind comes from. And it goes straight down toward the AV valve. All right. Well, ultimately, a defect in the top of this Venetian blind that now is made up of two septae, the top is really a secundum defect, and defects at the bottom are primum defects. Now, let's start with this sinus venosus ASD. So basically, the IVC and SVC enter the atrium, and that little widening, you get the IVC gets there, and then it widens out into the atrium. Well, right on the other side of the wall there is the left atrium. So if you have a hold there, there will be connection over to the other side. So this is the sinus venosus ASDs. They're either where the IVC enters or where the SVC enters. Another type of ASD, which really is just an interatrial communication. Remember, they're not supposed to have any communication after birth, and everything's all closed up. But a coronary sinus ASD allows that. So basically, as you know, the veins of the myocardium drain into the coronary sinus. So they get their blood supply from the coronary arteries, right above the aortic valve. Then they drain into the coronary veins, and all the veins empty into the coronary sinus, which is kind of a big vein that runs along the bottom of the heart. And it runs along the bottom of the heart and empties into the right atrium. Now, think of it as kind of like a heating duct running just under your floor. So it's running from the left atrium to the right atrium, and then it turns, makes a right angle up into the atrium, just like a heating duct that has its vent on the floor. That's how it goes. It comes along underneath the floor, and then it turns and vents upward. That's what the coronary sinus does too. Now, normally, all of the blood goes through the duct, comes up the vent, and out into the right atrium. None of it goes to the left atrium. But if you were to take off the roof of the duct or cut into the floor, what'll happen is, that heating duct will send air into both the atrium and the right atrium and the left atrium. Same way with this. If the coronary sinus is unroofed, that means returning blood can get back into the left atrium and the right atrium. So an interatrial connection has been made. Now, one of the reasons for confusion when it comes to ASDs is that all sorts of names are used, and they're kind of used carelessly. Here's a paragraph right out of Abu Hamid's book, and they're talking about the septum secundum, and the fact that they say that the septum secundum is primarily due to a presence of a defect in the septum primum, that's kind of confusing. So let's rewind, start from the beginning. Let's review our terms. So a foramen is a hole. An ostium is a hole. So foramen and ostium are often used interchangeably, which is enough to confuse you. Yeah, when you see it's foramen secundum or ostium secundum, well, yep, they are the same thing. And then lastly, a septum, of course, is a wall. All right, so since there was this confusion, I went to several other books to look it up and see how they avoid confusion. Well, Abu Hamid refers to this, quote, septum secundum defect, whereas Jack Rychik's book from Penn refers to it as a secundum defect. And the difference here is Rychek states that primum and secundum, when you're talking about atrial septum defects, are the holes, not the walls. So Rychek's book doesn't ever use the term septum secundum defect. It uses the term secundum defect, and they're really referring to the hole. All right, so ASDs are really ostium primum defects, ostium secundum defects, or more commonly, primum defects, secundum defects. But they're never septum primum defects. All right, I went to another source also, and I found that the way that they describe it is also helpful. So, a primum ASD is where the foramen, primum, remains open. All right, remember that was the Venetian blind that came down and it was on its way to the crux of the heart or endocardial cushion. If you get incomplete fusion of the septum primum and the atrioventricular endocardial cushions, you get a primum defect. The primum defects, incidentally, happen to be more common in Down syndrome because you get disruptions to endocardial cushion development. So Down syndrome, primum defects. Down syndrome, also we're going to learn, is atrioventricular septal defects. Secundum ASD refers to the ostium secundum or foramen secundum remaining open. And again, this is the most common type of ASD. It accounts for 80% of them. So the way that happens is you have either excessive reabsorption of the septum primum. Remember those little holes formed a whole bunch of little holes. The little holes joined together and formed a bigger hole. Well, if that process is haywire and gets too much, well, then that hole is very big. The ostium secundum is really big. Or, well, that's how they define it. I'll get into more in a little bit. But the point is, think of it as a primum defect is the foramen primum stays open, ostium primum stays open, or secundum ASD is the foramen secundum or ostium secundum stays open. All right, so with the primum defect, you can see that green septum never actually made it down to the bottom. It didn't get there to the crux and it left a gap. That is a primum defect. A primum ASD is where the ostium primum is still open. All right, so here's that University of Texas cartoon of how the septum form. You can see that first you got a septum primum, it comes down, then it forms a little hole in it. Then the septum secundum comes down, and the septum secundum almost gets there. It gets almost to the crux, and then it attaches like that. And it's right down at the bottom where the septum primum should have touched the endocardial cushions, but doesn't. That's a septum or a primum ASD, ostium primum ASD. All right, Let's talk about a secundum defect. Remember, we're not talking about the septum secundum, we're talking about the ostium secundum. So, a secundum defect is a secundum ASD, also known as an ostium secundum defect. Oh, there's a mistake. I'll fix that. Or a foramen secundum defect. That's an important mistake. All right, I'll fix that. All right. So basically, it's an ostium or foramen secundum defect. So it can either be excessive reabsorption, so you can see that green window there, the septum or ostium secundum, is super big. So that's one way you can have a secundum defect. But the other way you can have a secundum defect is the foramen ovale is super big. So there is actually a problem in the formation of the septum secundum, but that problem in the septum secundum resulted in a very big foramen ovale. Again, when you put those two septas together, it doesn't cover up the hole. The septum secundum is still open. So, yeah, those are our two choices. Either the hole on the right's too big or the hole on the left is too big. But either way, when they come together, they're not closed. That's how a secundum defect happens. All right, let's review. There are two walls. The septum primum has two holes, ostium primum, ostium secundum. The septum secundum is the second wall. It only has one hole, and that is the foramen ovale. The ostium primum closes. If it doesn't close, you've got a primum ASD. Ostium secundum, the one that formed by fenestration, well, if too much reabsorbs, it's too big, and the ostium secundum and the foramen now overlap, so the secundum doesn't close, so you have an ostium secundum defect. Alternatively, like I just said, you can have the foramen ovale is way too big. The septum secundum didn't form right and left a really big foramen ovale. Either way, the ostium secundum doesn't close. Now, the diagnosis of a secundum defect is rarely made antenatally. One of the reasons is there's just a lot of false positives and false negatives. And the size of a foramen ovale can vary a lot antenatally. So I said that one of the reasons you can have a secundum defect is the foramen ovale was too big. What's too big? Well, that's the problem. We don't have a definition of what the size is supposed to be. They just vary a lot. So for that reason, we hesitate to make that diagnosis. All right, well, in general, what are the things that tip you off? Well, if you don't see any septum above the foramen ovale, well, it's the upper part that's a secundum defect. So if you can see in the picture at the right, you can see there is a septum in the bottom part of the atrium, then there's the foramen ovale, but there's nothing above it. So that is a secundum defect. Another way, besides failing to see the septum up there, is failure to see the flap of the foramen ovale. So, okay, move on. So how do you diagnose a primum defect? Well, if you fail to see the septum between the foramen ovale and the crux. So you either fail to see the septum or that little portion of septum is not continuous. And the one over on the right shows that there's an open foramen ovale with a little flap that you can kind of see. Then there is part of the septum, but then there's a gap before it gets to the crux. That is a primum defect. Here's just a few more examples of example is of a primum defect on the left, where you have a foramen ovale, a little flap right over top of it, but then there's a gap before the septum reaches down to the crux. All right. Now, normally, if you have a primum defect, the flow tends to be right to left. That is the net flow all the time through the foramen ovale. Even though it's a little bidirectional at times, overall the net movement is from right to left. The stuff coming back from the IVC is pointed right at that hole and it shoots right across. So the normal thing is shunting right to left. If you have a primum defect, it also is the same, right to left. It just happens to be right next to the foramen ovale. So here's some pictures of a primum defect, and then there's some blood flow through that, and it is going from right to left. Let's see. So over in the next picture, you can see another example of right to left shunting. Now look back at the one on the left, in the middle. That's in the next slide. And what that shows you is that this can be confused with a dilated coronary sinus. Particularly that one in the middle there. You've got this little defect, and then you've got this line that makes it look like a coronary sinus. What that actually is the flap of the foramen ovale. Remember, the flap of the foramen ovale is like a little circle. We just happen to be catching one edge of it that makes it look like a straight line. But the point is that it can look like a dilated coronary sinus. Now, the way you can tell the difference is if you put on the color. Remember, the blood is going along the bottom of the heart in the coronary sinus from the left side to the right side. It goes under the left atrium on its way to the right atrium where it will dump out. So there, the blood is clearly left to right. And that will help you differentiate a dilated coronary sinus from a primum ASD. All right, and here's a couple more pictures. Basically, you have a dilated coronary sinus, and the flow is from left to right. And the one that's an ASD is from right to left. All right, sinus venosus type is very difficult to diagnose. Not only prenatally, but even afterwards, it's still hard to figure out. The picture on the right there, you can kind of see you're looking at a bicaval view, and it seems like there's a little interruption in the wall there. Well, that's what a sinus venosus ASD looks like. I've never made that diagnosis. All right, coronary sinus, also difficult to diagnose. The main thing with coronary sinus type ASD is that you suspect it. And why would you suspect it? Well, it's often with a persistent left superior vena cava. So if you've made the diagnosis of left superior vena cava and you see a dilated coronary sinus, you just need to be aware that it could be a coronary sinus type ASD. That's really more of a concern for the pediatric cardiologist. So they'll search for it. If they've got a baby with a persistent left SVC, they will search for this and try to figure it out. And particularly if the baby has symptoms. And those symptoms are, you've got blood returning from the left superior vena cava, which is the left side of the head, left arm, and they go down to the coronary sinus and head across, and they're supposed to get all the way back to the right atrium, but if it's unroofed, the deoxygenated blood goes into the left atrium and gets pumped out to the body. So when you pump out deoxygenated blood to the body, the baby turns blue, which is cyanosis. All right, this is just a little entity here that we occasionally see, a redundant foramen ovale flap, also called an aneurysm of the flap of the foramen ovale. And generally, To meet that criteria for that, the flap needs to be more than halfway across the left atrium. Now, sometimes it's so redundant that it can kind of flap back and forth, and the picture on the right shows that it actually flapped back into the right atrium. The only, that might make you think that there's some isomerism, but in those cases, you'll see it flap back over to the left. Well, for the most part, they don't have much in the way of significance, but they can cause ectopic beats. That flap, if it's banging on the wall of the atrium, it can stimulate an ectopic focus of electrical activity and set off a PAC. Now, they can also cause a left ventricular obstruction, that this big billowing sail of a flap of the foramen ovale kind of gets in the way and starts obstructing left ventricular inflow. And if you obstruct the inflow, you're going to have a smaller ventricle. So if you have a small left ventricle, you're thinking coarctation, ventricular disproportion, but you may have an explanation if you have a big redundant flap of the foramen ovale. All right, let's move on. All right, so what are some common associations? Well, primum defects, tend to be part of atrioventricular septal defects, but they have a high association with Down syndrome. Secundum defects, they are associated with a lot of things, and one of the notable ones is Holt-Oram. Sinus venosus defects tend to be associated with pulmonary venous return abnormalities, and then coronary sinus defect is persistent left SVC. So you've got a persistent left SVC, a dilated coronary sinus, and the roof of that coronary sinus is affected. Here's the summary slide. But basically, if you suspect an ASD, then you move on and try to figure out its location. Is it the bottom of the septum near the crux? Is it the top of the septum over the foramen ovale? Or is it seen in the bicaval view and make it a sinus venosus type? And you're really probably not going to diagnose the coronary sinus one. All right, let's move on to the next chapter, ventricular septal defect. Well, ventricular septal defect is the most common congenital heart disease. And there are 4 types, and they are based on location. And basically, you can see that the wall of the interventricular septum is a triangle. You can see it's pointy down at the septum, and it's wide up by the tricuspid valve. That triangle there is kind of divided into the thick part, muscular, and the part just beneath the valve. So that is the inlet VSD. The other parts of the septum are between the aortic outflow, or between the left ventricular outflow tract and the right ventricle, is a little strip of septum. That is the membranous, or sometimes called perimembranous VSD. And then if you go up even higher, the pulmonary artery has a little, outflow tract there, and just on the other side of that is the left ventricle. That is an outlet VSD. Well, 80 to 90% of VSDs are muscular. An inlet VSD is where the inlets are. The inlets are the mitral and tricuspid valves. The outlets are the great arteries. So an inlet VSD is between the tricuspid and mitral valves. Therefore, you can only see that in the 4-chamber view. You have to be down at the bottom where the inlets are to see an inlet VSD. This happens to be the type that is associated with an atrioventricular septal defect. We said that the ASD is a primum type, and we're telling you now that the one for the ventricle is the inlet. So an AVSD is basically an inlet VSD and a primum ASD. Well, muscular VSDs are the most common in fetal series. So here we go with a bunch of different muscular VSDs. And a membranous or perimembranous VSD is the most common in neonatal series. Well, why is one more common in fetuses than in newborns? Well, one of the main reasons is most of the muscular VSDs close during pregnancy. So by the time the baby's delivered, there isn't one anymore. Another thing includes the fact that of the VSDs, we tend to miss more of the perimembranous ones than the muscular ones. All right. Well, the perimembranous VSD is basically a defect in the perimembranous or membranous septum. And we said that's the thing that's between the LVOT and the right ventricle on the other side. So, the place you're going to find a perimembranous VSD is in the LVOT. Now, the LVOT is supposed to have septo-aortal continuity. There's a septum line, and it goes right into the aortic line. Now, there is an angle called the septo-aortic angle, but this loss of continuity is the tip-off that you've got a problem with the membranous septum. An outlet VSD, very hard to find, but the outlet VSD is between the RVOT and the left ventricle. So the pulmonary artery or the right ventricular outflow tract, that little, they call it a conus, the place where it goes from a wide right ventricle to a pulmonary artery-sized pulmonary artery. That funnel there, or cone, is called the conus. And on the other side of that is the left ventricle. So the place you're going to find it is in what we call the short axis view of the right ventricle. So it's RVOT / short axis of the right ventricle. That's where we see an outlet VSD. They're not that common, so there's a good chance we're going to miss them. All right, well, how do you make the diagnosis? Well, certainly if you're using color, you need to be perpendicular to the part of the septum that you're interested in. You need to do that to avoid artifact, because if you're parallel to the two inflow tracts, you can get artifact that makes them look like they are connected. So you need to get perpendicular to the septum and then turn on the color. The flow in a ventricular septal defect is typically bidirectional. The only times it's not, where it doesn't go back and forth, red, blue, is when you have ventricular outflow obstruction. That makes pressure high in one side all the time, so it tends to be unidirectional. Here's an example. We've got bidirectional flow. All you can see is turbulence across the septum, but when you put on the spectral Doppler, you can see that it goes to and fro. In fact, one of them, the part below, is the E and A of filling, and then what happens is the one that is during systole, you can see it goes the opposite direction. So in general, during diastole, it goes right to left, and during systole, it goes left to right. All right, let's kind of do some practice here. What kind of defects are these? All right, yep. What you have is a bidirectional muscular VSD. It's actually two muscular VSDs, and they are both bidirectional. The one you see over on the next page, or the right side, is in the 5-chamber view. So the one that you're going to see in the 5-chamber view is a perimembranous one. That septum between the aorta and the right ventricle is the membranous septum. Again, they're showing it as bidirectional. All right. Now, this is that en face view with 3D where you're looking at a triangle sitting on its side. So left atrium's kind of off to the left of the 3D picture and the right ventricle's to the right. So you've got this triangle-shaped septum. And if you look at the big picture over there on the right, what you'll see is the slice right at the very bottom of the triangle is the inlet. That's what you see in the 4-chamber view. That's where the inlet VSDs are going to be. The next one up is the LVOT plane, and that's where there's a big hole here. So this is a perimembranous VSD. It's a large one, and you can see that it's not in the 4-chamber view, it is in the LVOT view. And if you go up even further to the RVOT view, that is the outlet septum. That's where you would have an outlet VSD. All right. Well, if you suspect a ventricular septal defect, then the next thing is, well, describe the location. Is it an inlet seen in the 4-chamber? Is it muscular, also usually seen in the 4-chamber? Or is it up in the membranous or outlet portion? The ones that happen to be up in the perimembranous and outlet portion are also the ones that are associated with the great arteries. There's the mistake. Okay, got it. So if you've got a tetralogy of Fallot and there's an overriding aorta, we're talking about the perimembranous portion of the VSD. So generally, great artery problems that come along with VSDs, those are the ones, perimembranous and outlet. Here, you've got a bunch of obligatory associations, meaning all of them actually have to have a VSD as part of it. And there are a whole bunch of them. Chapter 21, Atrioventricular Septal Defects. So let's review some synonyms. We've got an atrioventricular septal defect, also called AV canal defect, also called endocardial cushion defect. They're all the same thing. Probably the one currently most in use is AVSD, at least in textbooks, but you'll hear pediatric cardiologists refer to them as AV canals and cushion defects frequently. All right, well, when it comes to a complete atrioventricular septal defect, that means there is a defect in the atrial septum and the ventricular septum, and that atrial septal defect is down near the bottom part, near the crux. The whole thing about these AVSDs is they happen at the crux of the heart. So you've got a primum ASD and you have an inlet VSD. That combination is a complete atrioventricular septal defect. Now, a partial atrioventricular septal defect, you'll have a primum defect, but you actually have two distinct AV valve annuli. So there are two orifices. So the complete atrioventricular septal defect, there is one single orifice with multiple leaflets, but basically there is one single orifice in this common AV valve. A partial ASVD means there are two distinct annuli, two distinct valve rings. Therefore, there are two orifices. You will see two, color flashes going through that area. All right. Now, so how do you make the diagnosis? Well, first of all, you'll suspect it because there is linear AV valve association, linear AV valve insertion, but there is no large ventricular septal defect. So typically you have a primum defect, you still have linear insertion, but there are two separate orifices and no big VSD. All right, so complete AVSD. Well, basically, you're supposed to have the tricuspid attached to the septum a little further down toward the apex, or apical displacement of the septal leaflet. But if it's not, it's even with the mitral. That is called linear AV valve insertion. And with the common AV valve, you've got two ventricles sharing one orifice. And you can see in diastole, there is no crux. The valves open up and there's just a gap there. Here's another picture of diastole. Diastole means the ventricles have relaxed and the valves have opened to fill them. When the ventricles contract, those AV valves close. Now, if we've got a common AV valve, those valves basically open wide and there is no crux. There's one single orifice just coming straight on through. And when there is systole, the common AV valve should close. Now, sometimes it's incompetent, but it will close and you'll see this linear, this line that goes straight across. That is basically the leaflet of a common AV valve. So that line that goes straight across is linear insertion. This is the common leaflet of a common AV valve, and that tells you you've got an AVSD. A lot of times the ventricular septal defect is better seen in diastole. The valves will be open and kind of out of the way, and you can see the defect better. Now, another thing that makes you suspect an AVSD is a short atrioventricular length. So the picture on the left is normal, and basically you've got a ventricle length that is longer than the atrial length. But on the picture on the right, well, actually it still is longer, but it's not longer to the same degree. So basically that atrioventricular length is less. Atrioventricular septal defects are commonly associated with heterotaxy. Color can be used to find a single orifice. You can see in the middle bottom one, it's not that obvious, since the one in the middle top is much more obvious, where it comes in through one orifice and then separates into the ventricles down at the bottom where there is a septum. Another thing that helps you figure this out is AV valves are often incompetent, meaning the blood does not stop from going back the wrong way. It goes back the wrong way. And you can see regurgitation of this common AV valve. And that can help you figure it out, because sometimes it's not so obvious. You're not really sure. You're thinking, well, maybe there are two flashes of color. I don't know. Well, certainly if there is regurg and it's located right in the center of the heart, that is an incompetent AV valve. Whereas things like tricuspid regurg or mitral regurg are off to their respective sides. Now, frequently, people like to term them balanced or unbalanced AVSDs. Usually they are balanced, meaning they are centered, basically right over the right ventricle and left ventricle, so there's the same amount of flow. If they are unbalanced, it's usually kind of centered a little bit more over the right ventricle. But if that's the case, you may see right ventricular, left ventricular disproportion, and you suspect coarctation, which is good because it actually does come with coarctation a lot. All right, so you can see some examples of unbalanced AVSD. The color flash into the right is significantly bigger than the color flash into the left. So, yep, this common atrial ventricular valve is centered a little bit more over the right ventricle. Less commonly, it could be the other way around, where it's kind of over the left ventricle a little bit more, so the left ventricle's a little bit bigger. All right. Well, you can see all these septal defects with a million different things, but 58% of the time, an atrioventricular septal defect is associated with Down syndrome. So if you see one of these, you should be talking genetics. All right. What else looks like an atrioventricular septal defect? Well, sometimes just a plain old inlet VSD can make you think of an atrioventricular septal defect. The difference is with an inlet VSD, the tricuspid valve and mitral valve offsets, where the tricuspid valve is further to the apex, that actually should be okay. Sometimes you can be confused by a dilated coronary sinus. And in those cases, the TV, MV offset should still be okay. But the other thing is, if you suspect maybe this is a coronary sinus, go look for that left SVC, because it will be associated with that. So, and what happens if you have a linear valve attachment, but you can't find anything else? You can't find an atrioventricular septal defect, whether it's complete or partial. You just can't find that. Well, it actually can be normal to have a linear valve attachment. And some of the babies with Down syndrome don't have atrioventricular septal defects, but they do have linear valve attachment. So even though it's possible that linear valve attachment can be normal, you should really be thinking, nope, there may be an actual AVSD, and you should also be thinking this could be associated with Down syndrome. All right, and here is the summary of slides, and you can see that the tip-off that gets you into the AVSD is linear insertion of the AV valves. We know that it can be possibly normal, but it really deserves extra evaluation. And that's all we've got for today.